We are live now.
Yeah, thank you. So good evening and welcome you all for this evening. The API ICP postgraduate virtual training program. We have with us from this week onwards for 12 weeks from faculties from Continental College and postgraduate from Continental College. It's my pleasure to welcome our professor and head of the department, Dr. Shivakumar sir, for this evening as a faculty. Really, thank you, sir, for accepting our invitation. Thank you, sir, for joining.
Thank you.
And we have Dr. Anjana Madam. She's the assistant professor in the Department of Neurology, Continental College. Welcome you, madam, and thank you, madam, for accepting our invitation and joining today.
Thank you,
And
sir.
we have with us Dr. Deepak, the final year postgraduate from Continental College. Welcome,
Thanks.
Dr. Deepak, for this evening. And we have with us our National Vice President and Secretary, State Chapter of Tamil Nadu, with us, Dr. Palnipan, sir. Welcome you, sir, for this evening. And I request the faculties and the postgraduate to take over the further proceedings of the session by requesting Deepak to start presenting the case and requesting the faculties to take over the further sessions of discussion as if we are going to do the discussion in the examination, starting from discussion on the history part and step by step the discussion on the examination, clinical skills demonstration, as well as the discussion on the differentials, as well as the discussion on the treatment point of view also. I request Deepak and the faculties to take over further proceedings, please.
Yeah, Saravanan, before that,
Yes, sir.
our heartiest welcome to South Zone, South Mid Zonal API ICP Master Class. Our heartiest welcome to our Professor HOD, Department of Medicine, Shivakumar sir. Sir, heartiest welcome, sir. So,
Thank you.
You agreed for the next 3 months, really, on behalf of South Zone, South Mid Zonal API, our heartiest welcome to our my own medical college, Coimbatore Medical College. Shivakumar sir, heartiest welcome.
Thank
you. Archana madam, heartiest welcome. So
Thank you, sir.
every week we are doing the PG master class. Monthly once we are doing the master class, question and answer, rapid fire question answer. Every fourth last Friday of every month we are doing the only master class, that is rapid fire question and answer in the super specialty. And really it's going in this is the 4th year we are going to complete, really more with all the support of various medical college professors. We are doing the program in a wonderful manner. My closest friend Dr. Saravanan is taking care. In between I am coming and we'll teach the students regarding the examination cases, how to elicit the history, all the thing, detailed long case like we are discussing. So over to the faculties, the process, you can take over the session. Over to Dr. Shivakumar sir.
Yes. Good evening. I request the postgraduate Deepak to start presenting the case. Madam, shall we start?
Yeah, please. Deepak, no worries. And do it instantly. All the best.
Okay. Good evening, Shivakumar sir, respected Anjana ma'am, and respected panel members, and my dear colleagues. My name is Deepak. I am from 3rd year postgraduate from Coimbatore Medical College. Today I am going to present a CNS case, a case of paraparesis. History. A 57-year-old male who is a resident of Tirupur, working as a tailor, studied till 10th standard, who presented with the chief complaints of numbness of both the foot since past 2 months, with the weakness of both the lower limbs since past 20 days, with the difficulty in maturation since past 10 days. History of presenting illness. Patient was apparently asymptomatic 2 months back. Then the patient developed complaint of numbness of toes of both the foot, which was insidious, symmetrical in onset, gradually progressive to involve both the foot up to the level of ankle in next 10 days. Numbness then progressed to involve the level of both the knee in next 1 month. It was associated with the pins and needles sensation in both the feet. It was associated with the complaint of decreased perception of pain over both the lower limb. He was not able to feel warm and cold water while bathing. It was associated with the complaint of decreased perception of clothes over both the lower limb. No history of band-like sensation over the trunk. No history of neck pain, back pain, or radicular pain. No history of electric shock-like sensation on bending the neck. No history of swaying while washing the face. There was no history of decreased sacral sensation. There was no history of sensory symptoms in both the upper limb. He was able to
Sir,
perceive
sorry to disturb you, Deepak. You are not audible to me. Hello? Deepak?
Okay, ma'am. Okay. Yes, ma'am.
Hello?
Hello? Ma'am, am I audible, ma'am? Hello, ma'am? Hello?
Madam, is it audible? Hello? Madam?
Ma'am, am I audible?
I think you are audible. Madam's connectivity is not good, probably. Her connectivity is not good. You are audible, Deepak.
Yes, sir.
Is it audible? Is it clear?
Ma'am.
I think her connectivity is not good. She's not responding. Probably you can
Hello, ma'am.
request her to switch off the video.
Sir?
Ask her to switch off the video that gets a better connectivity than to keep this video on. Let us switch off
Okay,
the
sir.
video first. It will be better connectivity will be there.
Okay, sir. Okay.
Let's pass on the message to her to switch off the video. Because she is keeping her video on, that makes the connectivity
Okay,
a bit slow. And now she switched off her video. She switched off her video, but
Hello, ma'am.
Hello, sir.
yeah,
Hello?
yeah, you
Ma'am, am I audible now, ma'am?
Sir, I'm not able to hear his presentation, sir.
yeah. Can you please come again, Deepak, once again? Can you hear me, madam, now?
Sir, it is the volume is very low, sir.
Okay,
Okay.
ma'am. Am I audible now, ma'am?
Deepak, your volume, I can hear you, but very, very low voice. I don't know, is there any problem with connection or not?
No, it's not a
So
connection,
please
madam.
do something, sir. It is not audible clearly.
Probably your volume output can be raised, madam. That makes the other's voice to hear in a better quality. Your
What, sir?
volume, your phone volume can be raised.
Yeah, yes, I have done it already. It is already in
Okay.
full volume.
Okay. Deepak?
Deepak,
Yes, sir.
little bit
Yes, sir.
increase your speaker volume, mic volume.
Okay, sir. Okay.
Because madam's
Okay.
voice is very clear to us.
Yes, sir. Yes, sir.
So you raise.
Sir, unfortunately, I can't hear him. So that's why I don't know why. Initially, it was okay, sir. Now
Okay.
only there's a problem.
Raise your voice, pa.
Yes, sir. I'm doing it.
Is it okay? Better now, ma'am? Hello, ma'am?
Hello, yeah. Deepak, tell me.
Can you hear me now?
It is still the same only. You can ask the IT team to do something about it. I don't know why I have put it in maximum volume.
Exicon?
Hello.
Yeah, there's a problem with the madam's audibility of voice from the other's phone. What can we do for that?
Actually, sir, there might be some issue in the system. Actually, we can hear the speaker's voice also.
Yeah, meaning that the issue with the madam's phone or speaker, is it that one?
Sir, there might be some issue on the system.
On the system on
Yeah.
the receiving end or the delivering end?
Yeah.
The
So just
problem with
requesting madam sir, just to rejoin the meeting again.
Okay, okay. Madam,
Yes, sir.
can you please disconnect once again and rejoin, madam?
Okay, I will rejoin, sir. Okay, sir.
Rejoin,
Sure.
rejoin, please. Yeah. Deepak, just wait for a minute. Let us
Okay,
join
sir.
that.
Okay.
Yeah.
Yes, sir. Yes, sir. Yes, sir.
Madam, madam, can you hear us?
Sir. Hello.
Ma'am, can you
Yes,
hear me
yes, yes,
now, ma'am?
Yeah,
Hello,
yeah.
ma'am.
Tell.
Is it audible now, ma'am?
Yeah, audible.
Okay, ma'am.
Go ahead from the beginning, Deepak, please.
Okay, ma'am. Sir, today I'm going to discuss a case, a CNS case, a case of paraparesis. A 57-year-old male who is a resident of Tirupur, working as a tailor, studied till 10th standard, present with the chief complaints of numbness of both the foot since past 2 months, with the weakness of both the lower limbs since past 20 days, with the difficulty in menstruation since past 10 days. Patient was apparently asymptomatic 2 months back, then he developed numbness of toes of both the foot, which was interior symmetrical in onset, gradually progressive to involve both the feet up to level of ankle in next 10 days. Numbness then progressed inward the level of both the knee in next 1 month. It was associated with the pins and needle sensation over both the feet. It was associated with the decreased perception of pain over both the lower limbs. He was not able to feel the warm and cold water while bathing. It was associated with the complaint of decreased perception of clothes over both the lower limbs.
Okay, sir.
No history of bad like
Class இருக்கேன். I will call you back, sir. The API.
no history of bad like sensation over the trunk. There is no history of neck pain, back pain, or radicular pain. There is no history of electric shock-like sensation on bending the neck. There is no history of swaying while washing the face. There is no history of decreased acrid sensation. There is no history of sensory symptoms in both the upper limbs. He was able to perceive the close sensation over his tongue. It was associated with the history of aware surprise chapel since past 20 days. There is a history of difficulty in walking in the uneven ground. History of buckling of knees was present. It was followed by the difficulty in getting up from the squatting position since past 15 days. There is a history of difficulty in climbing upstairs. There is no history of difficulty in mixing food or no history of difficulty in buttoning or unbuttoning of shirts. There is no history of difficulty in combing hair or reaching the overhead of this. It is associated with the complaint of difficulty in turning from side to side. There is no history of difficulty in lifting the neck from lying position. There is no history of breathing difficulty. There is no history of thinning of limbs or muscle twisting. It was associated with the stiffness of both the lower limbs, and there is no history of stiffness in both the upper limbs. There is no history of diurnal variation in the weakness. Patient developed difficulty in urination since past 10 days. He was able to perceive the bladder fullness and able to hold the urine. It was associated with the history of increased urge to void the urine. There is no difficulty in initiation of voiding of urine. It was not associated with the complaint of giddiness, palpitation, reduced sweating, or skin changes.
Okay.
There is no complaint of headache.
One question. In which
Yes, sir.
neurological disease The autonomic nervous system may present a catastrophic picture.
Sir, any lesions in the thoracic spine?
Pardon?
Sir, in lesions in the thoracic spinal cord, sir, it will present with the autonomic reflexia, sir. Then lesions in the thoracic spinal cord
Which clinical,
around
leave alone the level of lesions, which clinical
Okay, sir.
condition the patient will have an autonomic stroke? It may compromise the life of an individual. Guillain-Barré syndrome,
Sir. Okay, sir. Okay, sir. Okay. Okay, sir. Sir, there is no history of, no complaint of headache or loss of consciousness or speech disturbance or memory disturbance or emotional disturbance. There is no history of difficulty in appreciating smell. There is no history of blurring of vision, loss of color vision or double vision. No history of difficulty in eye movement or dropping of eyelids. There is no history of difficulty in appreciating sensation over the face. There is no history of difficulty in chewing the food. There is no history of deviation of angle of mouth or drooling of saliva. There is no history of loss of taste. There is no history of hearing loss or ringing sensation in the ears or vertigo. There is no history of natural regurgitation of food, difficulty in swallowing, or hoarseness of voice. There is no history of difficulty in turning head from side to side. There is no history of difficulty in protruding the tongue. No history of difficulty in making the food bolus or marshalling of the food. There is no history of difficulty in negotiating through narrow pathways. No history of slurring of speech. No history of slippage.
Again, another question. If there is a difficulty in negotiating through narrow pathways, what are the other history the patient may give?
The patient will have swelling while washing the face.
One, wash basin sign. Number two,
Yes, sir.
the patient may have a frequent falls.
Yes, sir. Yes, sir.
Number three, the
Yes, sir.
unsteadiness may increase
Right.
during night. Okay. On closure of the eyes, the visual, if the visual compensation is lost, any sensory symptoms, walking on the cotton wool,
cotton wool sensor.
sometimes may. Okay.
Yes, yes, sir. There is no history of difficulty. There is no history of tremulousness of hands. There is no history of slippage of spillage of food. There is no history of slowness of activities. There is no history of reduced facial expression. There is no history of involuntary movements of limbs. There is no history of recurrent falls. Patient became bedridden since past 1 week, and he was able to walk with the help of attendant.
Name.
There is no history.
Deepak, name some of
Yes,
the
sir.
neurological disease that is associated with recurrent falls.
So it can be seen in the Parkinson disease, sir. Parkinson, supranuclear palsy. There will be complaint of recurrent falls, sir.
Okay. Craniovertebral anomalies. There
Yes,
any
sir,
chance for falls?
when the cerebellum peduncle is affected, there will be ataxia. So there will be
Supranuclear
Yes, sir.
palsy and Parkinson disease, they have a tendency to fall.
recurrent falls, sir. Yes, sir. So there is no history of fever, weight loss, or loss of appetite. There is no history of vomiting or low stool. There is no history of chest pain. There is no history of skin rash or joint pain. There is no history of cough with expectoration, no history of trauma. In past history, patient is not a known case of diabetes mellitus, systemic hypertension, pulmonary tuberculosis, coronary artery disease, cerebrovascular accident, epilepsy, thyroid disorder. There is no similar complaints in the past. There is a history of varicose vein in both the lower limbs, which was conservatively managed. No history of any drug intake or toxin exposure. There is no history of recent COVID vaccination. There is no history of dog bite. Personal history, the patient takes mixed diet, adequate sleep, which is used to take alcohol occasionally, which was stopped 1 year back. He is a non-smoker, married and has 2 children. Family history, patient is a first-born child of a non-consanguineous marriage. There is no similar complaints in the family. The family tree depicting the family of the patient, and there is no similar complaints in the family in 3 generations. Treatment history, he has not taken any treatment for the present illness. Summary, a 53-year-old male, right-handed individual, presented with a complaint of symmetric onset of numbness of both the feet since past 2 months, with the progress till the knee, with the loss of pain and temperature and touch sensation over both the lower limbs, with the weakness of both the lower limb, distal followed by proximal, with the truncal weakness, with the involvement of bladder, with no weakness of upper limb, neck or respiratory muscle, with no involvement of cranial nerve, cerebellum or extrapyramidal system, with a normal higher mental function, with a normal personal and past history. So the possible site of lesion will be spinal cord, and considering the weakness of truncal muscle from turning to side, and since there is no weakness in upper limb, so most probably the lesion can be thoracic level. Structures involved are bilateral corticospinal tract, bilateral spinal thalamic tract, and bladder.
Go for the symptom. We will
Yes,
go
ma'am.
back again. We'll start with
Yes, ma'am.
so what is the first symptom started?
First, the patient had first the symptom was numbness, ma'am. Numbness started on the both the toes, then progress to ankle, then up to knee, up the level of knee, over a duration of 1 month.
Okay. Is it symmetrically ascending, symmetrical involvement of the toes or
Yes, ma'am.
asymmetrical involvement?
According to history, patient was telling it was symmetrical in onset, and it was ascending, ma'am.
Okay. What about the pain and temperature? Was it also symmetrical or?
Pain and temperature was also symmetrical in onset, ma'am. But there is no
What about
ascending or
method?
descending. At the same time, she told simultaneously she didn't feel a decreased sensation or pain and loss of sensation over the lower limbs. There is no ascending or descending type of pattern, but it was also symmetrical in onset.
Motor weakness is also symmetrical. Yeah. And
Yes, ma'am.
what
Motor
type
weakness.
of the bladder is this?
Yeah, he has an urgency to hold them out. There is an increased urgency, and there is no difficulty in initiation of mixturation. There is no completed dribbling. So most probably my UMN type of bladder.
One. So what do you say? What can you say about the because it's bilateral and ascending? Yeah, from the lower. No involvement of upper limb. Only lower limbs are involved, upper limbs are not involved.
Yes, ma'am. Yes, ma'am.
Okay. So what are the things you will apart from what are the things you will consider in case of an ascending sensory symptom? What are the things you will consider? What are the structures you will consider?
In this case, there is a ascending type of sensory involvement, then ascending type of motor involvement, which the bladder involvement is present about. So,
can it be a peripheral neuropathy? That is my question. Can it be a peripheral neuropathy?
Bladder is less likely involved in peripheral neuropathy, ma'am.
Okay,
But there also we can. Yes, ma'am. There also we can get ascending type of. Yes, ma'am.
So, but
there also we can get ascending type of bladder less likely. Hello, ma'am.
That is less likely. But what happens when the numbness happens? The idea is involved the fingers. Generally, upper limb involvement may be absolutely.
Yes, ma'am. By the time it involved the. By the time it involved the hip, both the hip, mostly the upper limb will also get involved, ma'am, like in a glove and stretching pattern.
Okay. So, peripheral neuropathy is less likely. Can it be a sensory ganglion? Sensory ganglion, they present with what? And the ganglion, only sensory symptoms. No motor.
Yes, ma'am. Here, patient has only motor and bladder symptoms also present.
Yeah, they will present with ataxia. They will present with ataxia, and they may have this, upper limb also there. they won't know where to place the limb and all, and there will be
Yes, ma'am.
ataxia in the lower knee and no motor
Yes, ma'am.
symptoms. The same is the case with sensory radical. So we are considering different aspects based on the symptom. Okay.
ma'am. Yes, ma'am.
So from and last we can consider the fractopathy, because all the cracks, if it is involved in the spinal cord, they can also present. So it is also a possibility. What are the
Okay, yes.
the sensory tracts which are involved in this case?
Well, in this case, there is a spinothalamic tract is involved, ma'am.
Okay.
There is also pain and temperature also loss in this. Spinothalamic tract is involved, and the patient is complaining of decreased pressure from clothes, ma'am. So there might be an involvement of posterior column also, ma'am.
But no other obvious vision. That is no history of difficulty in walking in the dark, no history of any walking.
Yes.
These are not
No,
present in the history.
these are not.
But we will keep
they
that
are
possibility in mind. Yeah.
it's not. It's not.
And what about the motor weakness? How do you coming to the symptom analysis of the weakness? So it is initially the motor weakness, then progress to proximal. Without involvement of the upper limb, and there is a mild involvement of the trunk.
Yes, ma'am. Mildly not truncal weakness.
No
Yes,
neck weakness or no breathing difficulty. So this is
Yes,
the pattern of
yes.
motor weakness. So what are the
Yes, ma'am.
things? Can it be a peripheral nerve? Do you consider peripheral nerve in this pattern of motor weakness?
Peripheral nerve also we can get calculated, but not up to the left leg.
Yeah, proximal muscles are not usually involved in
Proximal left, yes, ma'am.
peripheral nerves. Only
Distal
distal muscles are involved.
Tongue muscles are also not involved, ma'am.
Okay, and also if you consider next is after nerve, it is plexus or radical. Yeah, plexus. First is plexus, but do you consider plexus in this case?
Well,
but bladder involvement is there, so it is
yes,
unlikely. So
yes,
and in view of the bladder symptoms, we can almost say for sure that it is a myelopathy along with motor, sensory, and also
Motor,
bladder
sensory.
involved.
Bladder involved.
Okay.
Yes, ma'am.
Okay, and then what about the this?
No, no. Hello.
What other history you will ask? Hello.
Hello. In this
See,
case,
it's an ascending pattern of motor and sensory. Yeah.
Yes,
So you
yes,
have
ma'am.
to consider GBS. In GBS, what is the thing? Any history of fever, diarrhea?
Previous history of any preceding diarrhea or fever we have to answer. And this case it is negative one. There is no
Negative.
fever or
Okay.
vomiting or loose or nothing like that.
Okay. And also it is very important to ask about any history of previous surgeries.
Okay, okay.
Why is it important?
And
why is it important?
there is, and the patient might previous surgery, ma'am, there can be.
See, in case of subacute combined degeneration, there can be a history of what bariatric surgery, gastric surgeries, bariatric surgeries. Okay, so that you have to rule out that also. Okay, you have to say there's no history of surgery and no history of any preceding symptoms prior to the illness. So that you have to say.
Okay.
Okay.
Yes, ma'am. Yes, ma'am.
Okay. So what is where is the possible site of lesion? Can you just go to the summary, please?
Yes, ma'am. Most of the site of lesion will be thoracic level of spinal cord. Since there is low limb involvement, truncal weaker, but no upper limb involvement. So possibly it can be at the level of thorax.
So if there is no upper limb involvement, what is the likely level of involvement of the thoracic spinal cord?
Below the level of T1,
Correct.
Can go.
Very good, very good. So that you have to say. So we are
Okay.
considering a case of it is a myelopathy.
Yes, ma'am.
So okay.
Yes, ma'am.
Then
Okay.
then go on to the examination.
Okay.
We'll go on to the examination.
Now, on general examination, patient is conscious, is moderately built and nourished, with a BMI of 25.8. There was no pallor, no icterus, no clubbing, no cyanosis, no pedal edema, no generalized lymphadenopathy, and bladder was catheterized. Vital signs are pulse 86 per minute, regular rhythm, normal volume and character. It felt equally in all palpable peripheral vessels. There is no radioradial or no radiofemoral delay. Blood pressure was 120/84 millimeter of mercury, measured in right upper limb in supine position. Respiratory rate was 18 per minute, abdominal thoracic side. Saturation was measured 98% on room air, with a height neck ratio 12.7.
Okay, what is the normal height neck ratio?
Ma'am, the 13.6 is the cutoff. If more than 13.6, there is a risk of spinal cord combustion.
No. See, what is the importance of height neck ratio?
If it is
Not in this case, but generally.
That more than if it is more than 13.6, there will be.
See, normal height with short neck. So that means more than more than 13.6 is abnormal. So that may indicate a CV junction anomaly.
Yes, ma'am. Yes, ma'am.
Okay. Go on.
On head to foot examination, the skin and appendages were normal. There was no facial asymmetry. There is no cataract, discharge from eyes. There is no rashes over the skin. No neurocutaneous markers. There is no cutaneous markers of TB or SAV. There is no peripheral nerve thickening.
1 minute.
Yes.
What are the neurocutaneous markers that may have a bearing on in this patient? It is that.
Sir, in this patient, so we have to look for any process of any neurofibroma to rule out check for a neurofibroma sports.
No,
Check for neurofibroma.
Neurofibroma. Number 2.
Sir, then it can be due to tuberous sclerosis. So we have to look for the actually macules or Chagrin fat or cornex tumor.
This patient,
fibroma will be there.
asking this patient, this history, this examination, this patient. So neurofibromas, intraspinal lesions. Okay. Huh?
Yes, sir.
Go.
Yes, sir. On nervous system examination, higher mental function, patient is conscious, oriented to time-place person, right-hand individual, who studied up to 10th standard. Memory, immediate, recent, and remote memory are intact. Language, fluency, comprehension, naming, and repetition were normal. Cranial nerve examination, olfactory nerve, he was able to.
Deepak, one thing is,
Yes, sir.
the patient has completed 10th standard of exam. Up to 10th standard, in a CNS case, postgraduate had to tell mini mental score.
Okay, sir. Okay, sir.
Yes. Usually it is an ignored one because the patients are coming from a below 8th standard or 10th standard. In this patient, you have to do it. It is an important one in examination. Okay. Huh?
Yes, sir. Yes, sir.
Next. Go ahead.
On cranial nerve examination, olfactory nerve, he was able to process smell in normally in bilateral nostrils. Optic nerve, visual acuity was 6/6 in both sides, with the field of vision was normal. Color vision was normal in bilateral eyes. Fundus examination was normal in both eyes. Third, 4, 6 nerve, the extracellular movements were normal in both eyes, right and left eye. There was no nystagmus present. Pupil size was 3 millimeter in both eyes. Pupillary reflex was present in both the direct and indirect pupillary reflex are present in both eyes. Accommodation reflex is present. Trigeminal nerve, there is a sensation over the face is normal in both eyes. Sensation over the face is normal. Muscles of mastication normal in right and left side. Corneal reflex and conjunctive reflex are normal. Jaw jerk is present. On facial nerve, wrinkling over the forehead is normal. Closing of eyes against the restors were normal. There is no deviation as a label for. There is no deviation of angle, mode. He was able to blow the cheek and whistle. Taste sensation over the anterior two-tailed tongue was normal on right and left side. Vestibular cochlear Renate said air conduction that more than bone conduction was normal in the right and left ear. Weber's test there were no lateralization. 9-10 touch nerve, uvula was in midline, gag reflex was normal, collective movements were normal. Spinal axillary nerve, the shrugging of shoulder against left side, it was normal on right and left side. Turning of head from side to side against the left end, which was also normal in both the sides. Hypoglossal nerve, there is no wasting or fasciculation. The protection triangle was normal, tone of the tongue was normal, and tongue movements were normal. On motor system exam.
Excuse me, Deepak. What are the important cranial nerves you will look for in a case of myelopathy? What are the most important? Yeah.
In the upper cervical level, that lower cranial nerves, 9-10 level nerves can be involved now. Or it can be the foramen magnum syndrome.
Yeah, that is true. And also in CV junction anomalies, it can be involved.
Yeah. Also in second nerve, optic nerve can involve due to so there will be papilledema. Or third nerve can also involve. So there can be downweighting nystagmus can be present. Or in
downweighting nystagmus is present in which condition?
My third nerve.
See, in CV junction anomalies, foramen magnum syndrome, downbeat nystagmus may be there. Second cranial nerve can be involved in which condition? With myelopathy. What are the diseases you will think of?
The foramen magnum syndrome can be involved.
The optic nerve, that's what I asked. Optic nerve with myelopathy.
Neuromyelitis optica.
Correct. Very good. Neuromyelitis optica. Even multiple sclerosis. Okay. And optic atrophy can be seen in subacute combined degeneration. Okay. Sure. Continue.
On motor system examination, the boys in the 10 centimeter about medial epicondyl, it was on right side it was 36 centimeters, left side there was 35 centimeters. In forearm, there it is measured 10 centimeters below the olecranon, 25 centimeters in right side, 25 centimeters in the left side. In the thigh, it is measured 18 centimeters above the patella, it was 42 centimeters in right side and 41 centimeters in the left side. In the leg, it is measured 10 centimeters below the level of tibial tuberosity, 35 centimeters on right side and 35 centimeters on left side. There is no.
So there is no asymmetric wasting.
No,
there's no asymmetric wasting.
Okay. Yes, ma'am. Tone, it was upper limb, it was normal and bilaterally. Lower limb, it was hypertonic. Tone was increased. Spasticity is present in both the lower limbs. Power on shoulder, it was flexion, extension, abduction, adduction, internal rotation, and external rotation was 5/5 right and left side. At elbow, flexion and extension was also 5/5 on right and left side. Wrist, palmar flexion and dorsiflexion also 5/5 on bilaterally. In case of lower limb, flexion was 2/5 on power was 2/5 on right side, where it was 3/5 on left side. Extension 2/5 was on right side and 3/5 on left side. Adduction it was 2/5 on right side and 4/5 on left side. Adduction it was 2/5 on right side and it was 4/5 on left side. On knee, flexion was 2/5 on right side and 4/5 on left side. Extension was 2/5 on right side and 4/5 on left side. Ankle plantar flexion was 2/5 on right side and 3/5 on left side. Dorsiflexion was 2/5 on right side and 3/5 on left side. External hallucis was 2/5 on right side and 4/5 on left side. In case of reflexes, superficial reflex, the corneal reflex was present right and left side. Conjunctival reflex was present. Abdominal reflex was absent. Venous sign was absent. Rheumatic reflex was absent. Bulbocavernous reflex was absent. Anal reflex was absent. Plantar was extensor on both sides.
Deepak, what is this? What is the abdominal reflex root value?
Now in the upper abdominal, it will be T6 to T9, ma'am. In the mid level, it will be T9 to T11. Lower, in the hypogastric region, it will be L1 and L2. So more.
Okay, what is the nerve supply?
In the nose.
Yeah.
Nose of superficial abdominal reflexes. You were told the root values. Nose. Okay, no issues. No issues.
Okay.
Madam.
It is basically by the intercostal nerves. Okay, and iliohypogastric, hypogastric and ilioinguinal. Okay, what is Beaver's sign? How do you check for Beaver's sign, and what does it signify?
Now, if there's a lesion at the theta level, there will be upper abdominal muscles will be normal. There is a weakness of lower abdominal muscles, so we'll ask the patient to to flex his neck in the supine dorsum. So there will be an upward pull of the umbilicus. Since the lower abdominal muscles are weak, so the umbilicus will move upward.
Okay, so ask the patient to lie supine. Place your knee hammer, at the level of the, it is parallel to the umbilicus. Okay, and ask the patient to flex the neck. So what happens if there is a weakness of the lower abdominal muscles? What happens once the patient flexes the neck, the upper abdominal muscles will pull the umbilicus upwards.
Umbilicus upwards.
Okay, that is it. Yes, so what is the cremastic reflex root value?
Cremastic reflex is L1, L2. Okay.
So
L1, L2.
Okay, anal reflexes. So all the superficial reflexes, the lower limb are absent, and plantar is bilateral extensor, right?
Yes, sir. Yes, sir.
Okay. Next.
The deep tendon reflex, biceps 2 plus in right and left side. Triceps is 2 plus in right and left side. Brachioradius also 2 plus in right and left side. Finger flexion is present. Knee jerk is 3 plus in right and left side. Ankle jerk is absent on both sides. Patellar and ankle crosses are also absent.
Okay, what about the deep tendon reflexes grading? You know about it?
Yes, ma'am.
Yeah, tell me.
There is zero means there is no reflex, ma'am. 1 plus means there is a flickering or contraction. 2 plus is normal.
Pardon? 1 plus is?
Flickering, there will be minimum flickering only, ma'am.
It is present but diminished.
Present but diminished, ma'am.
Okay.
Then 2 plus is a normal, ma'am.
Okay.
2 plus is normally seen. 3 plus is exaggerated, ma'am. 4 plus is normally clonus.
Okay, markedly hyperactive. Yeah, with
markedly hyperactive.
Sustained clonus.
Contraction of the muscle.
Okay, see, grade 0, that is, this deep tendon reflexes are absent in spite of what? Genderasic maneuver, reinforcement maneuvers. So that is the genderasic maneuver. So what is genderasic maneuver?
Ma'am, we'll ask the patient to interlock the fingers and pull apart to as a reinforcement manner for the reflexes of lower limb.
Okay, and you can ask the patient to clutch one arm or one or both arms, side of bed, and ask the patient to look at the ceiling. Okay, grit the teeth. Okay, these are
cleansing the teeth in case upper limb
reinforcement manner. Correct. And if there is weakness with hyporeflexia, what does that indicate?
Weakness with hyporeflexia, there can be the element.
Hyporeflexia, LMN, lower motor neuron.
Element.
Yes, okay. Weakness with hyperreflexia indicates? Okay. What is the difference between lower motor neuron lesion and an upper motor neuron lesion? Tell me.
Upper motor neuron lesion, there will be the tract will be involved. And the lower motor neuron, there will be anterior concept or peripheral, the nerves will be involved. In upper motor neuron, there will be tone will be increased, reflexes will be hyperactive, there will be spasticity. On a contract and lower motor neuron, there will be tone will be decreased, hypotonia, hyperreflexia or areflexia will be there. And there will be marked wasting.
And in Okay, fasciculations may be there
Atrophy
in
will
case
be
of lower
present
motor
in case of
neuron.
lower motor neuron lesion. Okay.
Okay,
And
in
the
upper
plantar
motor
will be
neuron lesion,
this atrophy, diffuse atrophy will be there. Usually atrophy fasciculation is not seen. In long candy cases, diffuse atrophy
Okay.
might see.
pardon?
In upper motor lesion and long candy cases, there will be diffuse atrophy. Normally, atrophy fasciculation.
See, that is UMN.
won't be seen.
What are the UMN signs? That's what I asked. So there will be hypertonia, exaggerated reflexes,
Reflexes.
spasticity.
Spasticity,
Then
there will be
what
plantar will
else?
be extension.
Plantar will
Plantar will
be
be
extended. And there will be clonus. So don't
section.
forget clonus.
Okay.
Okay, and then velocity dependent increase in the tone.
Spasticity, there is velocity dependent and rigidity analysis it is not dependent on velocity.
Okay. Go ahead.
One more point I would like to add. In
Yes, sir.
UMN, it is group of muscles involved. In LMN, it may be group, it may be isolated one. Okay.
Yes, sir.
Okay.
Yes, sir. In sensory system examination, the pain and temperature, it was reduced perception below the level of nipple. Joint position, vibration, fine tense, it was reduced below this level of umbilical, that is theta level. Rhombic test, it could be examined if the patient was bedridden, and sacral sensation was such. Cortical sensation, tactile localization, 2-point discrimination, stereognosis and graphesthesia, it was present normally in upper limb.
And what about in lower limbs? Can you check cortical sensation in lower limb in this case?
No, if the primary sensory modality is affected, then we won't check for the secondary cortical sensation.
Okay. Go on.
Then cerebellum examination, the cerebellum finger nose test is normal, right hand, left side finger nose test is also normal. Dysdiadokinesia, it is absent. Pilschen test was not able to perform. There is no nystagmus, there is no scanning of staccato speech, gait couldn't be examined. Spine and cranium, there is no kyphosis, no scoliosis, vertebral tenderness at the level of C6 was present. Cranium was normal. There was no signs of meningeal irritation. Other system examination, cardiovascular system, S1, S2 heard, there was no murmur in all 4 areas. Respiratory system, no vesicular breath sounds are heard over the bilateral lung sheath. There is no added sound. Para-abdominal, it was soft, non-tender, bowel sounds were heard. Director examination was normal. Summary, there is a case of subacute onset of asymmetric ascending spastic paraparesis with involvement of sensory system and bladder, with no involvement of cranial nerves, with normal higher mental function, with normal cerebellum and extrapyramidal system, with vertebral tenderness at the level of T6. So the possible site of lesion will be spinal cord at possibly at the thoracic level now. The disease, since it is involved, there is more motor weakness, sensory involvement, and type UMN bladder. I like to think that's a compressive myelopathy.
Okay.
Possibly.
Go back to the deep tendon reflexes, please.
Yes, ma'am.
See there, I can see knee jerk is 3+ bilaterally, ankle jerk is bilaterally absent. So how do you account for it?
Well, there
Do
might
you
be
expect this compressive myelopathy, ankle jerk to be absent?
No, ankle jerk should be it should be present. It should be mostly exaggerated. But in case of spasticity, it should be exaggerated. It's absent here, so mostly it might be associated with any peripheral neuropathy.
Okay.
Or there can be subacute tubular degeneration, vitamin B12 deficiency might be there.
Okay.
So
and what about it can be as S1 radiculopathy also? This because ankle jerk alone is absent. What is the root value of ankle jerk?
S1, S2. S1, S2.
Knee jerk, basically it is S1 only. Okay, ankle jerk.
L2, L4, mainly L3.
Okay, finger flexion. You know the
T8,
root value.
T8, T1, maximum radius will be T5, T6.
But is this abnormal? Present, finger flexion present bilaterally. No other symptoms in upper limb.
No, it's normal only. There is no exaggerated finger flexion.
Okay. What other reflexes can you check for spasticity in, in upper limb?
Pectoral reflex we can check on.
Which one?
Pectoral reflex.
That is a sign of compression actually. Pectoralis.
Okay,
You can check for Wartenberg and Hoffman. What is Wartenberg sign?
Wartenberg, it is a plantar equivalent of an upper limb. We'll ask the patient to interlock the fingers and pull upward. Normally, the thumb has to extend and abduct. If the patient has, if it is in this case, there will be thumb will flex and abduct. And in Hoffman sign, we'll ask hold the middle finger, middle phalanx of the middle finger, and we'll ask flex the finger. There will be simultaneous
and tap
flexion
the
of
finger. Tap the finger.
Tap the finger. There will be simultaneous flexion of other fingers also.
Okay, fine. So what do you think? So all the reflexes are brisk. I mean, in the knee jerk is brisk, but ankle jerk is absent. And there's no patellar or ankle clonus with hypertonia or spasticity in the lower limb.
Lower limb.
Okay. So what is pyramidal pattern of weakness? You know about it?
Pyramidal pattern of weakness, there will be hypertonia, reflexes will be exaggerated. There will be extensor plantar, clonus might be performance.
Usually, in pyramidal pattern of weakness in the lower limb, it involves the foot and toe dorsiflexus. Okay, knee flexors and flexor and external rotators of the hip. So these are the weakness in lower limb. Okay, and in upper limb, it involves wrist, finger, elbow, supinators, external rotators, and abductors of shoulder. Okay, and spasticity is seen in the extensors of lower limb. Weakness in the other, what I mentioned earlier, spasticity in the extensors of lower limb. Okay. Okay, go ahead. So this is a thoracic spinal cord, and you think it is a compressive myelopathy with a possibility of coexisting neuropathy or radiculopathy.
Neuropathy or radiculopathy.
And you cannot rule out a quada equina syndrome, or quadus cona syndrome.
Yes, ankle jerk is absent, but knee reflex is present.
Pardon, I couldn't hear you. Sorry.
Mama, the ankle jerk is absent, but knee jerk is exaggerated. So there might be coda section can present. Coda it will be absent. Reflex might be there.
Okay. Check. And what is the level of lesion? Tell me the level.
Well, see, abdominal reflex, there are tongal weaknesses, so that tongal reflex is supplied by the T6 to T2. So motor level will at the level above the level of T6. Yes, the patient has decreased such pain and temperature below the level of nipple. That is nipple is at the T4. So sensitive level can be T4. The reflex in the abdominal reflex is upper abdominal reflex and axial. So upper is supplied T6 to T9. So that it can be above the level of T6, and vertebra there is a tenderness at the level of T6 form. So possibly above the level of T6 maybe the lesion.
Okay. So what do you think is the compressive myelopathy? What is the type of compressive myelopathy?
Well, this case, it can be extramedullary or intramedullary. Since our patient, this patient has vertebral tenderness, and there is ascending pattern of sensory involvement and motor weakness is ascending pattern, and there is a bladder, late bowel and bladder involvement. So those features generally point towards the extramedullary compressive myelopathy, but the root pain is absent. It is usually seen in the extramedullary patterns. It's absent one.
So
Mostly it will
how do you differentiate basically? So you feel it's an extramedullary
it's
compression. Yeah, in view of the vertebral pain, vertebral tenderness. But there's there's no root pain. In the history, there's no history of any root pain.
Root pain, yes.
And you have seen hypertonia, spasticity is there in the lower limbs.
Yes,
and there is ascending paresthesia.
Ascending paresthesia, yes.
And there is no sacral sparing.
Yes, yes, there is no sacral sparing.
And there is, what about any trophic changes or anything?
Trophic changes, trophic changes are
okay.
absent.
So in intramedullary lesion, the radicular pain and vertebral pain are absent. Okay.
Yes,
there may be a funicular pain, which is a vague central pain.
Yes,
okay. It is poorly localized pain.
yes.
So that is mostly seen in intramedullary lesion. And this UMN signs are intramedullary, lesions, they appear late.
Late in movement.
And
late
mostly element signs will be seen in intramedullary lesion. And the paresthesia will be descending.
Descending type of paresthesia will be there.
Descending paresthesia. So, and sphincter abnormalities, trophic changes, and they are more common. Dissociated sensory loss, sacral sparing is more common in intramedullary. Okay. What is the lamination of pyramidal tract and spinothalamic tract? Please tell.
Lamination, the pyramidal tract, it usually begins from the primary somatic sensory area.
No, I'm not asking the lamination of the fibers from cervical, thoracic.
From medial to lateral, it will be arranged. It will be arranged from cervical, thoracic, lumbar, and sacral. Lateral most will be sacral. Medial most will be cervical.
Okay. Intramedullary tumors, they begin in the midline, inside this central cord. Okay. So what happens is that the sacral fibers are the lateral most. So their sacral fibers are involved very late. Okay. That's why sacral sparing is common in intramedullary lesion. But extramedullary, it is not like that because compression is there. So sacral fibers may be involved early. Okay, so and asymmetric, and it will be early involvement of the sacral fibers. Okay, so there is no sacral sensations are reduced in extramedullary. Okay, so tell me about how do you differentiate between compressive and non-compressive myelopathy?
While compressive myelopathy, there can be bone pains will be present, bony tenderness will be present, root pain will be present, and it will be there is a sensory level, upper level of sensory level, like pain will be
clear
present.
sensory level. That is that's the hallmark of compressive myelopathy. Okay, and there may be some element findings about the UMN signs. There may be a band of sensory loss or reflex loss about the pyramidal.
Onset will be gradual in case of compressive. Onset will be sudden onset can be seen in case of non-compressive.
I didn't hear you. Sorry.
Onset will be gradual in case of compressive myelopathy.
And it is a short duration. Compressive myelopathy, a short duration. Okay, and it is asymmetrical involvement, like in this case. History-wise, there is no asymmetry, but examination, the power is different. Power is asymmetrical in both the lower limbs. So there is asymmetrical involvement. And there will be root pain and bone pain and tenderness, which is there in compressive myelopathy. What about the non-compressive myelopathy?
Non-compressive myelopathy, it will be the same vertebral pain, bone pain, vertebral tenderness, or root pain will be absent.
Okay.
And it will be mostly symmetrical.
Okay, great.
Which then it will be really depending upon the cause. It can be an acute presentation, and there is no definitive sensory level or
that is no clear level, and it is symmetricity, no root pain, no bone pain or tenderness.
tenderness.
So what do you think in this case?
Looking like compressive myelopathy, ma'am.
Compressive.
Extramedullary
Ah.
compressive.
Extramedullary.
Then,
Is it intradural or extradural?
Actually, there are features suggesting both. In case extradural, there will be bone pain, vertebral tenderness will be present in extradural.
So there is no bone pain in this case. It is vertebral tenderness is there, right?
Vertebral tenderness will be present, ma'am. And then
Okay.
root pain is also common in extradural. Root pain is actually absent images, but at asymmetricity, it will be more fall towards intradural vision.
Asymmetricity. Okay.
Asymmetricity is present in this case, but vertebral tenderness is also present.
Okay. So what are the extradural lesions what are the causes of extradural, extramedullary causes of myelopathy?
Extradural, extradural, ma'am, it can be any trauma to vertebrae or any metastasis or posterior intervertebral disc prolapse or any case, any kind of epidural abscess, epidural anesthesia. Epidural hemorrhage, epidural abscess or epidural hemorrhage.
Hemorrhage, abscess,
or any trauma, metastasis or any
herniated disc.
Herniated disc prolapse.
Okay. So what are the intradural causes of this?
Intradural can be due to any meningioma, schwannoma. It can be due to sarcoma or dermal tumor, or it can be due to any arterial venous malformation. Can be the cause for the intradurals. In intramedullary, it can be due to ependymoma, chordoma, or glioma.
Astrocytoma also. Ependymoma, astrocytoma. Okay. And we can also consider syringomyelia. What is syringomyelia?
Syringomyelia, there is a cavity, syringe has a cavity. So in condition with the increased ICP, there will be
it's a developmental anomaly.
Yes, developmental anomaly. It's mostly cervical spinal cord. It will usually in cervical spinal cord. So there will be outposting of the central canal movement to central canal. So there will be syringe formation.
Okay.
So
what is the pattern of sensory loss in syringomyelia?
Well, syringomyelia, mostly the spinal thalamic fibers will be involved. Syringomyelia, since the crossing is anterior to the central canal. So
crossing of spinothalamic fibers in the anterior commissure. So that is involved, right? So touch is preserved, but sensory pain and temperature is?
Yes, ma'am. Dissociative anesthesia can be seen.
Okay. So, okay. So what are the... Sorry.
Extramedullary, very important, common as a complete. Once you complete as a MD physician, complete physician, very commonest thing you have not mentioned, tubercular spine. Very, very common. Okay.
Hot spine.
Hot spine. Hot spine. Okay.
Okay, sir.
One relative patient actually obese. Okay. Complaining of the intercostal radiculopathy. Okay. Type 2 diabetes, intercostal radiculopathy, pain. Okay. So once we get the MRI spine, it shows the port spine T6 level. What's the commonest site for port spine?
The thoracic level is commonly seen, sir.
Pardon?
Thoracic spinal cord commonly seen, sir.
Lower thoracic, upper lumbar.
Lower thoracic.
Lower thoracic is very common.
Lower thoracic, sir.
Okay. In the actually, even a complete physician, the very important 4 things you should not afford to miss. Okay. Clinical practice. Tubercular spine. Okay. Tubercular spine, disc prolapse, or spinal canal stenosis, and spondylolisthesis. 4 important, very commonly in the practice you will be seeing. Okay. Common things are always common, rarer things are always rarer. Okay. Rarer manifestation of the common disease is much more common than common manifestation of rarer disease. So always these 4 things you should keep it in mind. Okay. Nowadays, all disc prolapse cases, any disc prolapse, cervical disc prolapse or lumbosacral disc prolapse, you need not do the surgery. Okay. There are some, what are the indications for doing the surgical management? Lumbosacral prolapse.
If there is intractable pain.
Okay. Intractable pain with bladder and bowel incontinence. Okay. Severe neuropathy, severe loss of sensorineuropathy. You have to do the surgery in severe radiculopathy and severe compression. Usually cervical disc prolapse or lumbosacral disc prolapse, usually when there is acute, for the first 2 months, the disc will be soft. During that period only, the patient will have severe pain. Okay, severe pain. After 2 months, the soft disc will become the hard disc. So even any type of movement will not compress the radiculopathy will settle down on its own. Okay. In diabetic patients, we are seeing a lot of mononeuropathy. Diabetic patients, cervical plexus radiculopathy, intercostal radiculopathy, and lumbosacral radiculopathy. Okay. Lot of radiculopathy you will be giving. Diabetic mononeuropathy we are seeing. Okay. For that, strict glycemic control and the drugs you should use which will reduce the glycemic variability. You can reduce that, you can get the relief. Okay. And pregabalin, all the things it will work out. Okay. Strict control and good glycemic control is very important. POTS pain always you have to suspect, and local tenderness will be there. Bulging may be there or may not be there. Always
there may be gibbous also.
Gibbous may be there. Okay, so always POTS pain when you are suspecting X-ray chest or HRCT thorax also to find out where is the focus, all the things. Okay, so once gibbous, everything you get it, absolute bed rest and various braces you have to apply, and ATT, steroids no role. Okay, so tubercular spine, POTS spine, you should not afford to miss. Always you have to keep it in mind. Okay, these 4 things are always common in your clinical practice. Okay, myelopathy, various, that is extramedullary, that is multiple myeloma, secondary spine, everything you have to keep it in mind as a complete physician. Yeah, you can go ahead. Sir, Sokumar sir, you can share the experience, sir.
Regarding the clinical examination, I told first in higher mental function test, mini mental score is expected in the post-graduation level, number 1. Number 2, regarding the carry spine, the history, you should ask whether there is any fever and all other things. Number 2, weight loss. Number 2. Then the pain, radicular pain. Then coming to the tuberculosis is really an enigmatic disease. It spares no one, whether you are rich or poor. The tuberculosis is always there. Okay, so you have to take it. All over the world, tuberculosis is the commonest disease. You have to apply your. Though the patient may have a lower level of the dorsolateral region is common, still we can have higher level also. We have seen quite a few cases. But because of the improvements in the investigation facilities like MRI or the opportunity of missing the diagnosis, even though we clinically miss, the investigation gadgets helps us to find out. Right. Coming to the another thing, the approach is whether the weakness is horizontal weakness or the level of lesion is horizontal or a vertical one. So in this case it is horizontal. So transverse myelitis has to be thought of as an initial diagnosis, because The transverse myelitis post-viral or post-vaccinal it has to be, but the history is always an abrupt one. It is the patient is apparently normal within a week, all the findings and with the complete loss of motor, sensory, and the bladder function. So that's why the transverse myelitis has to be thought of, but because of the prolonged history, almost 3 months, I believe. Okay.
Yes, sir. 2 months, sir.
Then regard one thing, CIDP, chronic inflammatory demyelinating polyneuropathy. It is one of the things we usually come across. We send the patient for the neurologist to have a nerve conduction. CIDP also may have a sensory signs, sensory symptoms, and motor symptoms also. I believe the madam will accept it. The CIDP is always diagnosed with the nerve conduction study rather than a clinical diagnosis. Okay. Then regarding the toxin exposure, what are the toxins you anticipate in the patient, given patients?
Sir, nitric oxide or cassava beans or lathyrism, we can see similar presentation.
Pardon?
Fluorosis, fluorosis or in nitric oxide exposure, lathyrism,
In
we
our
can see the
pesticides is the most common one. Okay, pesticide. Then toxins like alcohol also. Number 2. Number 3, I believe lead has some role. Madam,
Yes,
lead
sir. But usually motor symptoms, predominant motor symptoms, sir.
symptoms, sensory less, because most of we the people usually use the forged metals for our cooking purpose. The forged metals contain lot of lead in the during the preparation. So the nephrologist is always worried about the lead content in cooking vessels. So the problem in these things has to be thought of. Okay.
yes, sir.
Okay. Go ahead with the
Deepak, what all the site in the body TB will not affect? What all the parts it will not affect?
Sir, it will almost affect all except hair and nail. It will affect
Pardon?
hair
Except
and nail, hair and
hair
nail,
and nail and urethra.
urethra. Okay, sir.
Hair, nail, urethra.
Urethra.
3 important things. Okay.
Okay.
And one important cervical myelopathy. Nowadays, in the diabetic patient, severe B12 deficiency can also produce severe cervical radiculopathy. Okay, once you correct the B12 deficiency, the cervical radiculopathy will come down. Brachial neuralgia,
Okay,
cervical radiculopathy will comes down. Okay,
Okay.
B12 deficiency. All the patients, those who are taking metformin more than 1 gram, always suspect B12 deficiency. Okay, right. Go ahead.
What does B12 deficiency, which are the tracts which are affected by B12 deficiency?
It will cause the posterolateral collocytoma. So it will mostly affect the posterior column will be affected, and also it will cause the corticospinal tract also.
Okay, and usually starts as paresthesias in the hands and feet. Okay, along with this ataxia, spasticity. Okay, and what are the investigations you do in a case of subacute combined degeneration?
We'll look for the first. We'll look for the CBC. We'll look for hemoglobin, whether there is a presence of anemia, or we can look for the check for the MCV. If it is more than 100, we can check for any macrocytic anemia. And the peripheral smear also we can do. Then specifically
level will be low.
vitamin B12 level we can check.
Homocysteine will be high.
Yes, homocysteine will be high.
Okay. And one more point I would like to add, sir. Tuberculosis is more common these days because of the prevalence, increased prevalence of HIV. So that is a double-edged sword. So that is we have to keep tuberculosis as a possibility. And what are the causes of non-compressive myelopathy? We have already talked about compressive myelopathy. What are the causes of non-compressive myelopathy?
And non-compressive myelopathy can be inflammatory or non-inflammatory. Inflammatory can be due to infectious causes like bacteria, viral, or any parasitic causes, or any can be due to any autoimmune disorder like SLE, Sjogren, Behçet disease can cause
Before that,
or
just the commonest one.
it can maybe due to metabolic causes like
Multiple sclerosis, അല്ലയാ?
inflammatory,
Inflammatory multiple sclerosis, and also NMO spectrum disorders, MOG antibody disease. These are the causes of inflammatory. And CSF study is a must in these cases.
Yes, ma'am. So, oligoclonal plant is available.
Yes. Okay. And what is the investigation of choice in this case? So what is the first step you are going to do in this case?
To take taking the routine investigations, the investigations will be MRI scan with whole spine screening. In this case, it will be MRI dorsal lumbar spine with the whole spine screening.
Do you want to add a gadolinium contrast also?
Yes, contrast and
so what was the in this case, what was the MRI finding?
In this case, MRI dorsal lumbar spine with the whole spine screening, it showed the presence of intramedullary T1 hypoindex, T2 sphere hyperindex lesion, intramedullary, intradural, extramedullary location at D6, D7 vertebrae. Extra spinal cord meningioma with causing cord compression, mild cord edema. Meningioma was in this case.
No, lumbar sacral region were screened. There's nothing there.
There is nothing much.
Thoracic.
Only in thoracic level, there was a D6 level, there was a meningioma.
Okay. So it is very important to look for neurocutaneous markers in this case.
Yes,
and ideally, we should do a neuroaxis screening, whole neuroaxis, MRI brain also should be done, because if it is meningioma, you have to rule out elsewhere any lesion. Was it done?
Oh, okay. MRI brain was not done. MRI spine with MRI brain was not done.
Okay. Next, go ahead.
And treatment, the patient was given injection with myelopathy 1 IV for 5 days with the physiotherapy and bladder catheterization. Then in view of after taking the MRI, we found out it is meningioma, so the patient was taken over the neurosurgery department and the surgical extraction was done now. And the post-operatively, the power got improved. Left lower it become 5/5 and right it become 3/5. And the patient is discharged and the patient is currently on follow-up.
Okay. Good case.
Okay.
Sir, any points to add, sir?
Madam, I have one doubt because this patient, I believe it is in my unit. I gave prednisolone for 5 days. Is it justifiable as an evidence base? Because I gave only for a anecdotal, based on my anecdotal experience. Is there any evidence? Because getting an MRI takes some time, because the patient has to get the money, or in case of insurance, they have to get the approval. So during which, to prevent loss of time as well as the therapeutics has to be started early, I gave methylprednisolone. Is it justifiable? Madam?
Sir, actually, a single dose is justified, sir, while awaiting the MRI.
Because the timeline is always, we need 72 hours to get an MRI because of the availability, the long line of waiting. At least we will have 72 hours. So that's why I gave. So first dose is agreed, madam. In this situation, what else can be done? It's very difficult, tricky situation. That's why I
supportive management, sir. That is the key in this. And we pray for the speedy MRI. Deepak?
Okay.
Saravanan,
Yes, sir. Yes, sir. I mean, yeah.
your
Can
inputs,
you-
your inputs.
I think you're covered completely on the clinical examination points and clinical tips for the postgraduate to be reminded about examination, and Madam also covered different aspects, etiology as well as the clinical science correlation in relation to the site of involvement or localization, sir. I think I covered up almost all the aspects. Probably the time to be taken for only discussion on the therapeutics. I think it's not a forum for discussion on the therapeutics, basically for clinical science elicitation and discussion on the correlation of the science. I think well done, sir.
Okay, we have to change our curriculum, postgraduate curriculum. Therapeutics also should be done because the higher specialty people, they are including therapeutics in their clinical examination, I believe, madam. In DM.
Yes, sir. Yes, sir.
So we
The
have to.
DM is they're going to decide upon the therapeutics also because it's also part of their curriculum and examination assessment also. Whereas postgraduate level, the MD, we are not going to manage the neurosurgical aspect. We are not going to neuromedicine related, higher specialty related management. We are not going to do that. We are not authorized to do that. So in that case, we just know the outline about. I think that should be fair enough. That's the reason maybe the curriculum is designed such a way that to concentrate on the elicitation of the clinical science and interpreting the clinical science and relating the clinical science and coming out with a reasonably recent diagnosis. That's what I feel, sir. So
I
definitely,
think it is time to include therapeutics also.
yes, sir.
This is my suggestion.
Yes, sir. Okay. Yes, sir. Yes, sir. Yes, sir. Acceptable. Madam, anything else you want to say, madam?
I know, I feel Dr. Deepak has
Okay.
done a wonderful job. He has done a
Yeah.
very good presentation. I congratulate Shivakumar sir, head of the department, medicine, internal medicine department, Coimbatore Medical College, for such an excellent presentation, for guiding him.
Yeah.
Thank you,
I
madam.
think on behalf
Thank you,
of,
sir.
on behalf of, yes, sir. Yeah, on behalf of API ICP, really thanks Shivakumar sir for accepting and the faculty of this week. And really thank you, madam, also for discussion on this topic of the myelopathy, modern and common scenario for the postgraduates exam point of view. And appreciate Dr. Deepak for presentation and answering almost all types of questions raised by the faculties. Once again, thank you every one of you for this joining this discussion today. Make the the postgraduates get benefit out of your knowledge. And thank you every one of you and good night to all of you.
Thank you, sir. Thank you for the cooperation, sir. Thank you for the privilege. Thank you.
Yeah.
Good night.
Good night.
Thank you.
Dhanush,